Hello friends, I am Dr. Vikram Bhaskar and today I will be talking about approach to a child with arrhythmia. It is a practical topic, so I will be discussing the topic through various case scenarios. The learning objectives of this session are that by the end of this session, one should be able to recognize fast or slow heart rate, one should be able to differentiate between sinus and abnormal rhythms, they should be able to identify common tachy and bradyarrhythmias, and one should understand the basic principles in the management of arrhythmias. Fortunately, true emergencies due to unstable arrhythmias in children are very rare. According to one study, less than 5% of the emergency admissions in the pediatric population is attributed to symptomatic arrhythmias. Out of all arrhythmias, sinus tachycardia is most common, followed by supraventricular tachycardia. The idea is that every emergency physician should be prepared for diagnosis and to acutely manage various types of arrhythmias. So before we go on to the actual approach to arrhythmia, let us quickly revise electrical anatomy of the heart. So remember that all cardiac myocytes are capable of electrical conduction and they also have intrinsic pacemaker activity. Since SA node has the highest firing rate, it is the default pacemaker of the heart. However, if it stops functioning, other tissues can take over, but the rate will be slower. Second point to note down here is that each tissue has a different conduction velocity and a refractory period. You can notice in this diagram that while AV node has slowest conduction velocity, on the other hand, Purkinje fibers have the highest conduction velocity of 4 meters per second. Last point to note down here is that atria and ventricles are separated by an insulation of fibrous AV valve rings. So the only connection between atria and ventricle is through AV node. So if I have to draw an analogy, then one can say that conduction pathway of heart is like an expressway or a highway meant for fast conduction of electrical impulses. If some alternate route like a bypass road is taken, then you may still reach your destination, but ride won't be smooth, and that is when you get those bizarre looking QRS complexes on ECG. So the very first question in approach to arrhythmia is that what is normal sinus rhythm? So the two basic components of this definition is sinus and rhythm. Rhythm means the sequence. So the two prerequisites of sinus rhythm is that rhythm should originate in the sinus node, that is SA node, and each P wave should be followed by a QRS complexes. Now, how can we be sure that the rhythm has originated in the sinus node? It is characterized by a correctly placed P wave on ECG. What do we mean by that? That the P wave should always be positive in lead 1, lead 2, and lead AVF. It should always be negative in lead AVR. It should always be positive in all chest leads except for V1, which may be biphasic. The normal variation of a normal sinus rhythm can be sinus tachycardia, sinus bradycardia, or a sinus arrhythmia. In sinus arrhythmia, there is normal variation of the sinus rhythm along with the inspiratory and expiratory efforts of a patient. So the actual approach to a child with arrhythmia is a two-step process. In the first step, we analyze the rhythm, that is, what is the ECG showing to us. And the second step is to assess the clinical condition of the child. Please remember that final management of any patient will depend on both the component and not just the ECG analysis. Remember, we have to treat the patient and not the ECG. So we'll first going to talk about tachyarrhythmias. If we follow a systematic approach and ensure that these four sequential questions, then we'll be able to make a correct diagnosis most of the time. The first question is, we have to see what is the pattern of these QRS complexes. Are they regular or irregular? The second thing is that we look at the QRS morphology. Is it a narrow complex QRS or a wide complex? Then we look at the P wave, whether they are absent or present. And finally, we look at the relationship between P and QRS complexes, whether each P wave is being followed by a QRS wave or not. So it's a very simple approach. We go from backward to forward direction. We look at the QRS complexes first, then followed by P wave. We look at both the relationship between QRS and P, and that is how we approach a case of tachyarrhythmia. So let us look at a case first. A 7-month-old child is brought to you with a history of fever, diarrhea, and vomiting for 2 days. Respiratory rate is 68 per minute. Heart rate is 200 beats per minute. BP is 82 by 62 millimeter of mercury. The patient has feeble peripheral pulses with prolonged capillary refilling time. The saturation is 95% at room air, and ECG analysis show this rhythm. So what is your interpretation? So let us go step by step and apply this flowchart. So is it tachycardia? Yes, it's a tachycardia. We can calculate easily. You can see there are two large boxes between the two R waves. So 300 divided by two large boxes, it is roughly 150 beats per minute. So it's a tachycardia. QRS complexes, they are occurring at a regular interval. QRS morphology appears to be normal. P wave is present, and each P wave is being followed by QRS complexes, right? So this is a sinus rhythm with increased heart rate. That means it's a sinus tachycardia. Let us take a look at another case. Now, a 3-month-old baby is presented to you with a history of feeding difficulty and lethargy since 8 hours. So it's a very abrupt onset. Respiratory rate is 76 beats per minute. Heart rate is 240 beats per minute. Blood pressure is 80 by 60 millimeter of mercury. There are feeble peripheral pulses with prolonged CRT. Saturation is 96% at room air, and the ECG rhythm is now this. What is the interpretation and how will you manage this child? So again, let's go step by step. So what is the pattern and what is the heart rate? Is it a tachycardia? Yes, it's a tachycardia. You can see there is only one large box between the two R waves. So 300 divided by 1, nearly 300 beats per minute. QRS complexes, they are occurring at a regular interval, fairly regular interval. However, they are very narrow, right? These are narrow complex tachycardia. P wave, we cannot make out a definite P wave in this rhythm. And since we cannot make out P wave, there is no question of finding a relationship between P and QRS complexes. So this is a supraventricular tachycardia. The characteristic feature of the supraventricular tachycardia are that P waves are either absent or abnormal. There is a fixed RR interval. The heart rate is usually very high. Mostly in infants, it is more than 220 beats per minute, and in children, it is more than 180 beats per minute. And there is always a history of abrupt change. In contrast to sinus tachycardia, where so in sinus tachycardia, there is always a history will be present, which is contributing to sinus tachycardia. Like there is a history of fever or dehydration or fluid losses. So something which is contributing to sinus tachycardia, unlike in supraventricular tachycardia, where usually no preceding history is present and it is usually of abrupt onset. How do we manage a case of supraventricular tachycardia? So we always, like we do in any case of emergency, we have to stabilize the patient first. We have to take care of airway, breathing, and circulation. And then we see if the patient is hemodynamically compromised or not, whether the patient is stable or not. If the patient is stable, we can try Valsalva maneuver first or a carotid sinus massage. If the PSVT is persisting and if there is no contraindication to adenosine, then adenosine is the first line drug to treat PSVTs. If the PSVT is not resolved by giving adenosine and even at higher doses, then you can try calcium channel blockers. And if the patient still do not respond to calcium channel blockers, then you have to go to cardioversion. However, if the patient is unstable since beginning, then we go to cardioversion straight away. And when we say the cardioversion, we usually say synchronized cardioversion. So what do we mean by synchronized cardioversion? So synchronized means that the defibrillator will synchronize the electrical impulse with R wave of each QRS complexes. So we use appropriate energy levels in the defibrillator, and we usually start with a low dose of 0.5 to 1 joule per kilogram. However, if there is no response, we can go to higher dose of up to 2 joule per kilogram. The first line of drug for treating SVTs is adenosine. We usually give it by 0.1 milligram per kg and a maximum of 6 milligram in the first dose. However, if the patient do not respond to this initial dose, then we can go up to 0.2 milligram per kg up to maximum of 12 milligram. You have to remember that T half of this drug is very short, just 2 to 10 seconds. So we have to use a rapid 2 syringe technique to administer adenosine. It is a drug of choice for stable SVTs. However, even in unstable SVTs, it can be used if vascular access is good and ready to use. You have to keep a defibrillator always ready in case the adenosine fails. The side effects of this drug are flushing, chest pain, and dyspnea, and hence it is contraindicated in AV block and asthma. Now, why do tachyarrhythmias occur? There are primarily three mechanisms responsible for any kind of tachyarrhythmia, which are increased automaticity, re-entry, or triggered activity. So increased automaticity can be either enhanced normal automaticity, which can be caused by stimulation of sympathetic nervous system, or inhibition of parasympathetic nervous system, can be caused by ATP depletion like hypoxemia or ischemia, or digoxin toxicity and hypokalemia. Sometimes there can be abnormal automaticity, which is seen in acute ischemia or congestive heart failure responsible for tachyarrhythmias. The second mechanism responsible for tachyarrhythmias is re-entry, which is the most common mechanism seen in pathological tachyarrhythmias. So fundamental requirements for any tachyarrhythmias caused by re-entrant pathway is that yes, there should be an anatomical circuit should be present, but there should also be a zone of slow conduction has to be there, and there has to be a region of unidirectional block. Once all these three criteria are satisfied, then the re-entrant pathway can lead to tachyarrhythmias. The least common mechanism is the triggered activity, and it means that impulse depends on after depolarization. So heart cell contract twice, although it is activated only once. The typical example of this type of tachyarrhythmia is Torsades de Pointes. So let us look at one more case. A 12-year-old male came with history of drowning in pond around 1 hour back. The respiratory rate is just 32 beats per minute. 32 per minute. Heart rate is 150 beats per minute. BP is 78 by 56 millimeter of mercury. There are feeble peripheral pulses with prolonged CRT. Saturation is 90% at room air and ECG shows this. So what is the interpretation? So again, we will use our systematic approach. We'll look at whether there is tachycardia or not. Yes, there is tachycardia. Heart rate is nearly 200 beats per minute. QRS complexes are regular, but they are wide. Yes, you can easily differentiate this ECG from previous two ECGs where the QRS complexes were either normal or narrow. P wave, we again cannot make out P wave. So there is no question of relationship between P and QRS complexes. So this sort of rhythm is suggestive of ventricular tachycardia. So remember, there is only one differential diagnosis of a wide QRS complex tachycardia, that is VTAC or ventricular tachycardia. So how do we manage a ventricular tachycardia? So whenever you are deal with probable ventricular tachycardia, again you have to stabilize the patient first, and then you look whether there is any cardiopulmonary compromise is present or not. If present, then you go for synchronized cardioversion. Otherwise, the drug of choice to treat VT is either amiodarone or procainamide. Amiodarone is given at a dose of 5 milligram per kg over 20 to 60 minutes, while procainamide is given at a dose of 15 milligram per kilogram over 30 to 60 minutes. If there is no cardiopulmonary compromise and if the rhythms are regular and monomorphic, then you can try adenosine also. Always remember that whenever you are dealing with any arrhythmia, whether tachy or brady, you have to look for reversible causes like H and T's. There are 6 H and 5 T's, which you can remember by these mnemonics. So H represents hypoxia, hypovolemia, hypoglycemia, hypothermia, hydrogen ion, or hypo or hyperkalemia. While the T's represent tension pneumothorax, tamponade, thromboembolism, trauma, toxins, drugs, etc. And again, if you see carefully, in the brackets, I have written A, B, C, D, E, which means even in your primary survey, you can very quickly rule out most of these HNTs, right? So it is not very difficult or a time consuming process to look for these HNTs. You can very well do this primary survey in a matter of few seconds only and quickly assess whether the patient has any of these correctable causes or not. Let's quickly revise the tachycardias. So, for practical purposes, if you are dealing with a narrow complex tachycardia, you are most probably dealing with a supraventricular tachycardia. You just have to look whether the patient is hemodynamically compromised or not. If there is no hemodynamic compromise, you go for vagal maneuver first. If there is no response, then you give adenosine. If it fails, then you can go for synchronized cardioversion. If the patient is already cardiopulmonary compromised, then you can go for synchronized cardioversion straight away. Like I told you, for wide complex tachycardia, you are most likely dealing with a ventricular tachycardia. Again, you look at the cardiopulmonary compromise. If there is cardiopulmonary compromise, you go for synchronized cardioversion. However, if the rhythms are regular and monomorphic, you can try adenosine in these patients as well. Let us look at one more case. So now a 11-month-old female came to you with a complaint of cough and cold for 2 days. Respiratory rate is just 38 beats per minute, 38 per minute. Respiratory rate is just 50 beats per minute. BP is 90 by 62 millimeter of mercury. Peripheral pulses are good and normal capillary refilling time is present. Saturation is 98% at room air and ECG rhythm show this. What is the interpretation? So this is a bradycardia, yes. So approach to bradycardia is slightly different from those of tachyarrhythmia. You have to remember that bradyarrhythmia may occur because of the two reasons. There is either the problem with impulse formation or there is a problem with impulse conduction. When there is a problem with impulse formation, we'll usually label it as sinus bradycardia or sinus arrest. It means your SA node is not functioning well. Or there can be a problem with conduction, which can be at the level of atrioventricular node, which can be further categorized into type 1, type 2, or type 3 block. Or there can be a block at the level of bundle branch, which is known as bundle branch block, further categorized as LBBB or RBB. So in bradycardia, again, you have to look at your QRS complexes first, whether it is a narrow or a wide complex QRS complex. If it is a wide QRS complex with bradycardia, then you are dealing with a third degree AV block. If it is narrow, then you look at your P waves, whether they are present or absent. If it is absent, then it's a sinus arrest. If it is present, you look at your PR interval, whether it is normal and it is P is followed by QRS complexes, or it is abnormal or prolonged. If it is normal, it is sinus bradycardia. If it is abnormal or prolonged, you are either dealing with a first degree or a second degree AV block. So let us review one more case. An 11-month-old female, history of cough cold for 2 days, respiratory rate 38, heart rate of 50, BP 90 by 62, peripheral pulses are good, saturation is good. So let us analyze this ECG. So what do we have? We have a narrow complex QRS, yes. P waves are present. You can very well make out these P waves. Look at the PR interval. Is it the normal PR interval? No. The PR interval seems to be prolonged. So it is either first degree or second degree heart block. In this case, it is a first degree AV block. So what are the AV blocks we know? So it can be either first degree, second degree, or a third degree heart block. In first degree, there is only the PR prolongation, but each P is followed by a QRS complex. But the PR interval is more than 200 milliseconds. The second degree heart block is a partial kind of heart block where some waves are conducted and some are not, which can again be divided into type 1 and type 2. So second degree type 1 is also known as Vanky-Pack phenomena, where PR interval progressively lengthens until a P wave is not conducted or gets dropped. Type 2 second degree heart block, some P waves are conducted and some are not, some are intermittently blocked. While in third degree heart block, there is complete heart block and there is just no association between the atria and the ventricles. PP interval and RR interval are always constant and the QRS are usually wide. Let us look at one more case. A 12-month-old boy, he presents with history of cough and cold for 2 days, respiratory rate 30, heart rate again 50, BP 90 by 62, peripheral pulses are good, saturation is 98%. Now this is the rhythm. So QRS complexes, normal or narrow? Narrow. P waves are present. PR interval is normal and each P wave is followed by QRS complex. So it's a sinus bradycardia. So how do we manage a case of bradycardia? So again, we have to stabilize the patient first. We look at the A, B, C, and then we look at whether there is any cardiopulmonary compromise present or not. If there is a cardiopulmonary compromise present along with bradycardia, then you have to start cardiopulmonary resuscitation if the heart rate remains below 60 despite oxygen and ventilation. So first you have to correct oxygen and ventilation. So A, B, followed by C. If the bradycardia still persists, then you look if you have to continue with the CPR if the heart rate remains below 60 beats per minute. If it continues to stay below 60 beats per minute despite CPR, then you have to go on to your drugs like epinephrine or atropine. You have to look for correctable causes like HNTs, like we discussed previously. You have to keep on checking pulse every 2 minutes. If the pulse is present and bradycardia persists, you have to continue with your CPR and drugs. If the pulse is not present, then you have to go to pediatric cardiac arrest algorithm. So that was it. So my take-home messages from this session is that pediatric arrhythmias are not rare and are often missed. Systematic approach can lead to correct diagnosis in most cases. Outcome will depend upon early identification of the arrhythmias and the clinical status of the patient. Reversible and treatable underlying causes should be looked for in all the cases, and expert consultations are required for cases who are not responding to your standard line of management. Thank you.